Okay, I'm not going to get too hung up on the PowerPoint. I will touch on it. There were some specific things that we were asked to address, but on pages 38 and 39 of your conference brochure are the slides for this PowerPoint. Just a little bit by the numbers. Since inception of AB 109 in San Bernardino County, we've received approximately 6,200 PRCS cases. And just by gift of love, about 297 of those are transfers from other counties. I'm just saying. We have about 89% of those cases have been male, with 11% being female. I'll say 54% are sincere classifications as high risk, and the reason I say sincere classifications is because we do overrides for all of our PRCS cases to high levels of supervision until we have, through supervision, contacts and compliance records, before anybody may be considered for even being reduced to a medium supervision caseload. So all of our PRCSs come in at high levels of supervision. Since that time, we have 3 regionally based day reporting centers. We've received probably contacted at our day reporting centers about 4,800 clients that have received some form of service or intervention, even just being received, whether that's your orientation and assessment, whether that's having a contact with our co-located services at our day reporting centers, which I'll touch on a little bit later. We have about 684 cases that have been identified as having some form of behavioral health needs, whether that's co-occurring with substance abuse issues, but actually having some level of need from the lowest or to the highest level. But our behavioral health department has actually contacted approximately 2,800 of those returnees and done some form of assessment, providing some type of referral to community-based resources, or talking with our officers to identify something that they may need as well. With that being said, just a little bit of our overall CCC plan, which we completed in September 2011. We look at trying to do, of course, a balanced approach with community safety, rehabilitative services needs, and some form of intervention services as well. So with all of that being considered, we have officers, probation officers in every sheriff station and police agency in the county, with some of those agencies having 2. We have pre-release officers in all of the jails in our county. Our day reporting centers also have post-release reentry officers in all of our day reporting centers. In our day reporting centers, we have what we call primary partners, county partners, and those are people that are co-located. They're there every day, 40 hours a week, to provide services and assessments. I'll start not with DBH because I'll talk a lot about them, but we also have the Transitional Assistance Department, which takes on-site referrals to do healthcare services enrollments. For our county, that's Arrow Care, but of course now the Affordable Care Act and straight Medi-Cal services. They also do applications for CalFresh. They make outside referrals if an individual is eligible for CalWorks or for general relief. That's done at another TAD office. We have workforce development, which provides eligibility workers on site at all of our locations. Workforce development specialists who do assessments for transferable skills to determine if someone's able to train for employment services, job readiness, or potential placement for employment. We also have on-site public health, which offers a public health nurse who does outreach and education for holistic health considerations, screenings, and necessary referrals. We have had some difficulty filling our nurse practitioner positions, but we're looking at a new strategy to get that done. So once that's done, at all of the clinics that are located at our day reporting centers, we'll have a nurse practitioner and a medical assistant. A nurse practitioner is, of course, able to do lower level procedures, write prescriptions, so that's going to be in place. And then, of course, we have the Department of Behavioral Health. We have found that one of our primary needs is those individuals that are returning that do have diagnosed behavioral health needs. So for us, one of the biggest bangs for our buck was to put a large investment through agreement through our CCP into that area. So what we have for approved levels of services for staffing is and in the PowerPoint in your book, I believe I left out clinical therapist 2. So at each of those sites, there is a dedicated clinical therapist 1, clinical therapist 2, a mental health specialist, a social worker, a drug and alcohol counselor, and of course they have their own clerical support services. Some of those sites, I believe with the exception of our high desert site, does not have two mental health specialists, 2 social workers, because it's a smaller site. But still, we've seen producing some of the same numbers as our central location and what we call our West End location. So with that being said, our clinics, our particular day reporting centers, all have Medi-Cal certified clinics on site for mental health outpatient services at all 3. Our central site and our high desert site received certification in August, with our West End site having received certification previously and is also a certified drug and alcohol outpatient treatment services site. DBH uses a 2-tiered system to provide that, and just so you guys know, just to step away for a minute, our team is actually here. We have representation here from DBH, from public health, from workforce development. Our transitional assistance team is very busy with affordable care, so they're not represented today, but we're here, so. That first part is that case management component in phase 1, provides for initial screenings for mental health or drug or alcohol services, linking clients with community resources, including housing resources. We have dedicated beds through the Department of Behavioral Health for drug and alcohol clients, as well as those with straight behavioral health needs as well. They also partner with public health to do medical assessments and make the appropriate referrals to medical care and post follow-up for that. And they do an addition of other services too, facilitating classes on site, providing alcohol and drug education, assisting us with public presentations because we have a component that educates our community and faith-based partners in efforts to build their capacity, so they assist with that. Also monitor cases. In phase 2, they have mental health and alcohol and drug outpatient treatment programs, like I said, which are located at all of our DRCs. They also have day treatment services. They also connect clients that may not necessarily need services on-site at the DRCs or an off-site Colton clinic to other areas within DBH that they may benefit from. Examples of that may be someone could be a late-aged adult and maybe they do not qualify under AB 109 PRCS or mandated supervision. So they have a program called AgeWise that deals specifically with individuals that are late age and have behavioral health issues, so they would connect them with that resource. They have a series of clubhouses that deal with homeless mental health clients. They may connect them with that resource. So anything within that DBH network. If you're not eligible under AB 109, they will work to connect you with those resources as well. Moving into some of the other things that we were asked to address as part of this presentation, that's primarily how we've connected our justice population with services. But what are we doing to take advantage of expanded eligibility under the Affordable Care Act? We're participating in our county's new plan for Medi-Cal administrative activities and looking at how we can do claimable reimbursements under that. So some of those activities that we can claim reimbursement for is outreach and education to clients, referring them to our on-site TAD or to other offices to get enrolled in Medi-Cal services or services under the Affordable Care Act. Also, coordinating those referrals through our day reporting centers and identifying points of entry for Affordable Care Act applications. Any type of coordination of services, developing training. We recently finished a 3-hour training that we received STC certification for last week to provide a training for our officers for which they'll get training credit for 3 hours for the Affordable Care Act and how that will apply to us internally as a department. So those are just a couple of things that we're doing with that. Also, do we have any data regarding projections about the reductions in recidivism with individuals who receive mental health services or drug treatment? I would love to say, yeah, we do. We got that all under control. But to be honest with you, we are tracking our recidivism rate, but the subpopulation for mental health, we haven't done that. The reason for that is because when we began to do a literature review of some of the related research, the question that came into play with our research and analysis unit, how can we effectively do that if in fact we're not identifying the data sets we want to look at? Okay, so if we haven't looked at you coming into services immediately and how long you have done those services, then how can we begin to adequately assess the recidivism in that population if our method of doing that isn't consistent? So with us coming on board with the Medi-Cal services clinics, we're looking at ways to address that and how we want to specifically measure those components and how we're providing that service, how soon you get it, the frequency of service, how soon you were connected to that service, to give us a better view of how we want to track that recidivism. And when that's worked out, we'll do that. So that's it for now, and we'll just respond to anything else in questions. Thank you.